This material is made available to you by or on behalf of the University of Melbourne under Section 113P of the Copyright Act 1968. It may be subject to copyright. For more information, visit the University Copyright website.
Wonderful, acknowledging. All right. So yes, this is recorded. If you're not interested in being recorded, then please don't be here, leave this meeting, or otherwise just keep yourself on mute. And yeah, so welcome to this seminar. We've got Bonnie here, and Bonnie is well known in Werribee for her work in the past few years there. Here she is presenting the part of her master's research degree around Prednisolone, and this is where Bonnie's starting. Bonnie, over to you.
Awesome, thanks. Oops, let me just make sure my slides will still advance. There we go. Let me just, yeah, cool. All right. Thank you everyone for attending today. So this was a two-part project, and I'll start by discussing the background and aims collectively for my master's, and then I'll discuss each experimental chapter individually before finishing with our conclusions. So the drug of interest for this study was prednisolone, a widely used medication in veterinary medicine. Prednisolone is a corticosteroid, which can be prescribed orally as an anti-inflammatory, and at higher doses, it can be used as an immunosuppressant and is considered a first-line medication for a variety of immune-mediated diseases in dogs, as well as being used for cancer therapy. At low doses, it can be used to replace cortisol in dogs that have hypoadrenocorticism, also known as Addison's disease. Briefly, in terms of mechanism of action, prednisolone is a glucocorticoid that acts on the glucocorticoid receptor. As shown in this figure, once bound, the glucocorticoid receptor acts at a DNA level. It influences transcription and translation of multiple target proteins, and also has some non-genomic activity through both cytosolic and membrane-bound receptors. At physiologic doses, as given to a dog with cortisol deficiency, it enables essential metabolic functions. As concentrations increase, the net effect is anti-inflammatory, progressing to immunosuppressive at higher doses. So despite the assumed widespread use of prednisolone, there are no Australian studies describing prescribing practices in dogs. Out of the United Kingdom, there have been 3 papers to date describing corticosteroids prescriptions in dogs. These studies described median dose prescribed, dog demographic data, risk factors for prescription, and incidence of side effects. In addition to there being no comparable Australian studies, there's a lack of information about what prednisolone is commonly prescribed for and what factors influence dose prescribed. So one important consideration when prescribing prednisolone is its side effect profile. Side effects range from mild to causing significant morbidity. The dose makes the poison. As you may expect, higher doses increase the risk of experiencing these effects. Potential for side effects are likely to influence prednisolone prescriptions, and this is especially true for large dogs, which I'll elaborate on now. So anecdotally, it is believed that the size of the dog plays a role in the severity of side effects. This was recently substantiated by a study in the Canadian Veterinary Journal, which found the odds of a dog developing muscle atrophy or polyphagia during glucocorticoid therapy were increased by 30% for every 5 kilograms of body weight. Clinicians are wary of higher doses of steroids in larger breed dogs due to concern around side effects, and this has been translated into dosing guidelines. Experts recommend that dogs over 25 kilograms being treated for immune-mediated disease with an immunosuppressive dose of prednisolone be dosed by body surface area in meters squared rather than weight in kilograms to try and reduce drug exposure and therefore side effects. Despite this being a recommendation that could affect many dogs, there is little research in this area. So prior to now, only one study to our knowledge has actually investigated the role weight plays in the pharmacokinetics of prednisolone in dogs. A study by Nahm et al. Compared plasma concentrations of prednisolone between beagles with a mean weight of 9.9 kilograms and large mixed breed dogs with a mean weight of 29 kilograms after oral dosing. The study ultimately found that higher body weight dogs had higher relative plasma concentrations compared to smaller dogs at equivalent doses when dosed by weight in milligrams per kilogram. So you can appreciate this on the figure that I've got presented here, which is taken from that study. The y-axis plots the prednisolone plasma concentration and the x-axis time after prednisolone administration, with 3 curves showing their 3 treatment groups. So the blue line plots the small dog group, the beagles, who received 2 milligrams per kilogram of prednisolone. The red line is the larger dog group who received the same dose, 2 milligrams per kilogram. And you can appreciate that the peak plasma concentration in the larger breed dogs is higher and the area under the curve is larger and was found to be significantly so compared to the smaller dog group. You can compare this to the green line, which is the large dogs dosed by body surface area of 40 milligrams per metre squared, so approximately 1.3 milligrams per kilogram for that dog size. This curve is closer to the small breed dogs dosed at 2 milligrams per kilogram per day. So these findings are certainly very interesting and hint that an equivalent plasma concentration in a larger breed dog requires a reduction in dose. So why may a difference between these large and small dogs be? So allometry is the study of size or how characteristics change with size. And allometric scaling is an established concept in pharmacology where drug doses are scaled by body weight, usually as an exponent of body weight rather than linearly per kilogram. And this may be used to adjust drug doses across species of different sizes or between adults and children. The principle behind allometric scaling is that certain metabolic functions do not increase proportionally with each kilogram of body weight. Importantly, in pharmacology, drug clearance has been shown to not increase linearly with body weight. So veterinarians actually use allometric scaling in everyday practice, and for dogs this can be quite important as they come in a variety of body sizes. So for instance, dosing by body surface area, such as when we're using prednisolone for large dogs, features allometric scaling, as you calculate body surface area from body weight in kilograms to the power of 2/3. So this is shown in the bottom equation here. Another example is the equation for resting energy requirement uses an estimate of 3/4 when it's quantifying the relationship between basal metabolic rate and body weight. In the NARM study, the increase in area under the curve in larger body weight dogs compared to smaller dogs likely reflects larger dogs having proportionately lower clearance compared to smaller dogs. So to summarize this concept, area under the curve is inversely proportional to clearance, and clearance does not necessarily increase proportionally with body weight. So the NARM study demonstrated how weight can impact prednisolone pharmacokinetics in dogs, however, it had some limitations. So there were only 2 body weights examined, being around 9 and 29 kilograms. The smaller dog was exclusively one breed, beagles, so a breed-specific phenomenon could not be excluded. And additionally, the study groups were limited to 5 healthy individuals each. So the application of this information to a more diverse natural canine population who receive this drug for medical reasons is limited. So a solution to this limitation would be to study prednisolone pharmacokinetics in a sample of dogs that actually reflect the dogs that are receiving prednisolone in practice. And this is the concept behind population pharmacokinetics. These sorts of studies look to describe and quantify differences in drug pharmacokinetics between individuals with sources of variability, including disease states, sex, age, body weight. Once the impact of a given factor is understood, dosing can therefore be adjusted based on the category a patient may belong to. So a population pharmacokinetic study would have excellent applicability in a canine population, which is very varied, particularly by weight, and allow us to gain a better understanding of how body weight affects prednisolone pharmacokinetics. So with all this background in mind, we embarked on a 2-part study with the following aims. So for the first part, we wanted to describe prednisolone prescribing practices for dogs in Australia, given this was an area yet to be researched. Our aims were to describe the demographic of dogs receiving prednisolone and dose prescribed. We wanted to describe the indication for treatment and report on how often inappropriately high doses of prednisolone were being used, given this is a factor that may increase drug-associated morbidity. Given caution around dosing higher body weight dogs, we also sought to determine if any factors, including body weight, influence dose prescribed. We hypothesised that inflammatory conditions and anti-inflammatory doses were expected to be most common, and we did not expect body weight to influence dose prescribed. The aims of the second part of our project was to create a pharmacokinetic model for prednisolone from a sample of dogs that reflect those that receive this drug in practice. And we wanted to describe the effect of area under the curve produced by changes in body weight. A revised dosing strategy could then be created using this information, allowing for dose adjustments based on body weight. Our hypothesis was that increasing body weight will increase area under the curve relative to a static dose in milligrams per kilogram due to relatively reduced clearance, in larger dogs, that is. In terms of the exponent that would relate body weight to area under the curve, a hypothesis of 0.75 was proposed due to this being the exponent that is often assumed for relating body weight to clearance in previous studies. So now I'll go through the methodology and results of each project separately, beginning with the prescribing practices research. And this was a cross-sectional study using VetCompass Australia. So VetCompass Australia is a national database of anonymised veterinary records. And during our study period, 137 general and referral hospitals located in the eastern states of Australia contributed to this database. We used a keyword search to identify prednisolone-containing tablets or intravenous products in medical records between July 2016 and July 2018. And our inclusion criteria were that the dog had to have had a body weight recorded, have been prescribed a prednisolone-containing product, and that and I should say oral or injectable product, topical medications were not included, and that no individual dog could contribute data more than once. 2,000 randomly sampled medical records out of a total 19,378 medical records were manually reviewed by myself and contributed data. So data retrieved from these records were dog signalment and body weight, the dose of prednisolone prescribed, and this was specifically the initial dose before any tapering occurred. The dose in milligrams per kilogram and milligrams per metre squared was calculated, and the dose given to that patient was categorised as either physiologic, anti-inflammatory, or immunosuppressive based on the ranges depicted here on the slide. These categories are comparable to therapeutic guidelines, but we did create an intermediate category between the anti-inflammatory and immunosuppressive dose range, as there is no clear classification for this dose in therapeutic guidelines. And due to the limitations in tablet sizing, we wanted to create a margin between what we would categorise as an anti-inflammatory or an immunosuppressive dose. So the medical record was reviewed then to determine the indication for prescription based on the treating clinician's primary differential or clinical problem. And this was classified by body system affected and the clinically indicated dose for the disease being treated. So specifically, did the disease the clinician intended to treat warrant a physiologic, anti-inflammatory or immunosuppressive dose based on public recommendations for that disease? If the indication was unclear, the reason for prescription was described as unknown. So descriptive statistics were derived for those previously noted variables of interest, and then linear regression was performed to identify if any variables were associated with dose prescribed in milligrams per kilogram and milligrams per metre squared. A sample size calculation was performed for a linear regression model containing 3 explanatory variables with ability to predict a 5% expected effect on prednisolone dose. This calculated a sample size of 212 dogs, but we chose to review 2,000 records to increase the accuracy of our description, while also being practical in terms of the amount of time required to review medical records. And this ultimately was about 10% of the whole data set. To further investigate if body weight influenced dose prescribed, we also identified a small dog group and a large dog group, or breed rather, that were treated for the same disease for comparison. And we were specifically looking for a group with a large number of dogs for comparison, which I'll discuss later in my results. So moving on to those results, presented here is a table showing the global signalment data for the 2,000 entries reviewed. The median age was 73 months, with a slight predominance of males. A wide range of patient weights were represented, but with a median of 17 kilograms, and terriers were the most common breed class. The median starting dose of prednisolone was 0.83 milligrams per kilogram per day, which is an anti-inflammatory dose. Additionally, anti-inflammatory was the most common dose category prescribed, applied in 58% of dogs. Immunosuppressive dose, based on our categorization, accounted for 10% of prescriptions. So this histogram plots in milligrams per kilogram per day on the x-axis and the number of dogs receiving that dose on the y-axis. Sorry, plots dose. This data was non-normally distributed, but you can appreciate a peak here clustered around the anti-inflammatory dose range. So in terms of indication for prescription, the overwhelming majority of dogs were prescribed prednisolone for disease of the integument, namely dermatitis and otitis. Unknown reasons for prescription were next most common due to incomplete or unclear medical records, accounting for 5%. Endocrine prescriptions included Addison's disease, which was actually relatively uncommon, with only 8 dogs in total being treated for that disease. Cardiovascular disease was the least common, and this was exclusively just dogs being treated for heartworm. So this table compares the dose prescribed by category in rows against the indicated dose for the condition treated in columns. And we were interested in assessing how frequently dogs were prescribed an inappropriately high dose, so namely those receiving immunosuppressant doses when an anti-inflammatory dose was indicated. Due to tapering occurring, inappropriately low doses couldn't really be assessed for, and we didn't look into this. So 152 dogs, so in this little box down here, out of 2,000 were prescribed an immunosuppressive dose, 1.5 milligrams per kilogram per day or greater, for a condition that called for an anti-inflammatory dose, and this was 8% of prescriptions overall. So moving on, a linear regression was performed to identify factors associated with dose in milligrams per kilogram and milligrams per meter squared. And in the interest of time today, I'm just presenting the multivariable for dose in milligrams per kilogram, and the results of which is tabulated here and continued on to the next slide. So age, weight, sex neuter status, indicated dose, and body system treated specifically is on the next slide, was significantly and independently associated with dose in milligrams per kilogram. So our key variable of interest, weight, showed an independent negative association with dose. The regression coefficient quantifies that effect, and it quantifies the effect of each variable on dose. So for weight, for every increase in weight by 1 kilogram, the prednisolone dose prescribed was reduced by 0.005 milligrams per kilogram per day. Age also had a small negative effect on dose, with an increase in age by 1 year, reducing dose by 0.009 milligrams per kilogram per day. As expected, indicated dose was significant, with conditions indicating a physiologic or anti-inflammatory dose having a lower dose prescribed compared to immunosuppressive conditions, which was the reference category. So this table continues the multivariable data from the previous slide, but shows the effect of body system. So body systems such as hematopoietic and neurological in particular were associated with higher doses in milligrams per kilogram when compared to integument as a reference. The endocrine category is redundant here, as all dogs in the endocrine category are shared with the physiologic dose category, which was on the previous slide. So moving on from the linear regression, here is a comparison of a small dog breed and a large dog breed treated for the same condition for which we could compare dosage practices. Maltese dogs and Labradors were 2 of the most common breeds in the data set, and there were over 100 of each treated for inflammatory skin disease for which we can compare, with Maltese dogs representing a small breed and Labradors a large. So this table compares the key descriptive variables for these 2 groups, and you can see there was a significant difference in dose in milligrams per kilogram, with Maltese dogs receiving a higher dose than Labradors. Labradors did receive a higher dose when dosed by body surface area, likely due to the effect of relatively smaller increases in body surface area with increasing body weight. These 2 groups did also differ significantly by age, with the Maltese group being older, But as before, age and the multivariable had a small negative effect on dosing. And so if anything, this may have blunted the difference between the two groups slightly. So what have we gained from this study? So we now have a description of how prednisolone is used in the Australian dog population during the observed time period. The overwhelming majority of prescriptions were for disease of the skin and ears, likely reflecting how common this presentation is in practice. A limitation of this observation, though, is that it may no longer be current, as there are new and emerging treatments for inflammatory skin disease that are becoming more common in recent years. Encouragingly, we did see that prednisolone is mostly used as an anti-inflammatory, at an anti-inflammatory dose for inflammatory conditions. However, 8% of prescriptions involve the use of a dose of 1.5 milligrams per kilogram or greater for an inflammatory condition. And while this is a small number, it does highlight some inappropriate use of prednisolone in this population and therefore potential for increased drug-associated morbidity. Finally, in terms of factors influencing dose prescribed, we did find a small negative effect of weight in the whole cohort and also in the Maltese Labrador comparison. So this implies that clinicians are being judicious of weight when dosing larger dogs, but we acknowledge it would have been ideal to examine dosing practices between small and large breed dogs treated for immune-mediated disease, where dose recommendations are really clear for large dogs. But in this cohort, that group was relatively small. Other limitations are that we could not review every record that was eligible, and that we were limited by the clarity of communication in the medical record in terms of understanding the clinician's reasoning for prescription. So moving on to part 2, I'll now discuss the population pharmacokinetics study. So in this study, we enrolled client-owned dogs, adult dogs, receiving prednisolone orally for any medical reason. Due to the sampling protocol, they did have to be greater than 2.5 kilograms and amenable to IV catheter placement. Exclusion criteria included receiving ketoconazole or rifampicin, medications that have been demonstrated to alter prednisolone bioavailability via altering P-glycoprotein activity, liver failure, as the liver is the primary site of prednisolone metabolism, and also dogs could not be receiving any prednisolone topically due to the potential for systemic absorption. We performed a sample calculation using statistical software GPower3 and linear regression, and this approximated a required sample size of 50 to 100 dogs to document an effect size on area under the curve of 20%. Based on this, our goal was to recruit between 50 to 150 dogs, allowing for more dogs given the limitation of power calculation estimations. So dogs were admitted for blood sampling, and there were 3 hospitals used for patient recruitment. An IV catheter was placed for blood sampling, and a baseline blood sample was taken prior to any prednisolone administration. The dog's normal daily prednisolone dose was then administered, and blood sampling followed the ideal 10 time points described on this slide. These time points were chosen based on historical studies where prednisolone absorption has been found to be fast, and it typically peaks around 1 to 2 hours post-administration and is starting to approach 0 by 6 to 8 hours post. To estimate area under the curve, we wanted to be able to capture the peak concentration as well as observe declining concentrations. And the figure on this slide is a concentration time curve from a study on prednisolone bioavailability, which describes the expectations that we had. Because these were client-owned dogs, and we were seeing them in the hospital environment, there were times we could not adhere strictly to this sampling protocol, such as if the dog could not spend 9 to 10 hours at the clinic. This was acceptable for our methodology with a plan to have enough dogs and enough time points to overcome if some dogs only had limited sampling performed. Our original study design also featured a subset of dogs representing for an intravenous dose of prednisolone, but this was going to be performed internally to calculate bioavailability of prednisolone in our sample of dogs. But unfortunately, we could not source sterile prednisolone for injection and couldn't perform this part of the study. So patient samples were collected into lithium heparin before the plasma was separated and frozen at -80 degrees until processing. Prednisolone has been previously demonstrated to be stable, frozen at -20 degrees for at least 6 months. Prednisolone quantification was then performed using liquid chromatography tandem mass spectrometry with prednisolone D6 as our internal standard. Liquid chromatography has been utilised, tandem mass spectrometry has been used previously in numerous other studies for quantification of prednisolone with good accuracy and precision. Our lower limit of detection in this study was 1 nanogram per mil. So after quantification, concentration time curves were plotted for each dog's prednisolone concentration over time. And Dr. Andrew Woodward was instrumental to the rest of the data analysis, performing non-compartmental analysis to determine area under the curve estimations for each dog. He then used non-linear regression to describe any relationship between area under the curve, dose, and body weight. Plots were created describing area under the curve by dose at different patient body weights, different dog body weights rather, for comparison. So as a reminder from our aims, area under the curve reflects the total exposure, the body's total exposure to the drug after administration. It's proportional to the dose administered and is inversely proportional to clearance. So dogs with lower clearance would be expected to have larger area under the curve values. Area under the curve is also affected by bioavailability of the drug. So this needs to be consistent between individuals for any differences to be attributed to clearance. Because we didn't have an intravenous phase 2 experiment, we had to assume consistent bioavailability between individuals. So moving on to our results, 26 dogs contributed samples to the study, but only 25 contributed data, as one dog had such delayed absorption of about 6 hours before any prednisolone was detectable, and he was removed as an outlier. The median age of these dogs was 76 months, median body weight 19.9 kilograms, and dose received 0.44 milligrams per kilogram, with dosages ranging from physiologic to immunosuppressive. Median sample number taken from each dog was 8 samples. There were a variety of breeds included, with poodles and poodle crosses and cocker spaniels being the only two duplicated breeds, and there were a variety of medical indications for prednisolone. So here we have the concentration time curves for the 25 dogs, with plasma prednisolone concentrations on the Y and time in minutes on the X. And you can appreciate just by looking at this data that absorption time could be quite variable. So for example, dogs 22 and 23 in the bottom left have profiles we would expect based on previous work. So with peak absorption occurring relatively rapidly. Compare this to dog 9, 10, 15, and 26. So for these dogs, 4 or more hours after prednisolone administration, concentrations are still increasing. So this was problematic and created more uncertainty in area under the curve calculations in these dogs, as their concentrations were still increasing when observations stopped. So the formula depicted here was developed to describe the relationship between area under the curve, dose administered, and the dog's body weight. Hopefully you can appreciate this formula sort of follows a similar structure to the typical allometric scaling formulas on my background slide. A was the unknown coefficient in this relationship, and B the exponent. Nonlinear regression was used to solve this equation based on our data, and the exponent P calculated was 0.827. And this is similar to the typical exponent cited when allometric scaling is performed for clearance, which is 0.75. So this formula was then used to plot expected area under the curve at different prednisolone doses at different body weights. So the purpose of this is to allow comparison of dogs of different sizes. So walking through this, area under the curve is depicted on the y-axis and dose in milligrams per kilogram on the x. A separate graph is present for dogs of 5, 15, 30, and 50 kilograms, moving from left to right in increasing weight. The black line is the best estimate of area under the curve, with the grey area, the uncertainty interval, capturing 90% likelihood of the true value. So for ease, compare each graph at an immunosuppressive dose of 2 milligrams per kilogram, so this line. here in each of them. So that you can see for a 5 kilogram dog, the estimated area under the curve would be approximately 120,000. But for a 50 kilogram dog at the same dose, their AUC or area under the curve is estimated at 160,000, so higher. So these figures are different, but similar to the previous slide, but this time dose is described in milligrams per meter squared rather than milligrams per kilogram. Dosing in milligrams per meter squared would be recommended by current dosing practices for dogs over 25 kilograms, with 50 milligrams per meter squared typically considered immunosuppressive dose, though some clinicians won't actually go higher than 40 milligrams per meter squared. Again, compare dosing for each body weight at the higher dose limit of 40 milligrams per meter squared. And you can appreciate that dosing by body surface area doesn't normalize dose across different body weights in terms of area under the curve. A 50 kilogram dog at this dose has an estimated area under the curve of approximately 90,000, whereas for a 50 kilogram dog, 140,000. So what we have gained from this project was an understanding of how variable prednisolone absorption could be, including some significant delays in absorption compared to previous studies, absorption time rather. We hypothesize that this demonstrates the variability in gastric emptying seen in dogs, particularly in the hospital environment, where dogs are experiencing variable amounts of excitement or stress, even in these dogs which were actually quite laid back to even be eligible in the study. It highlights the limitations of observations performed on research dogs when translating that research in designing an experiment for client-owned dogs. We confirmed our hypothesis that body weight does influence area under the curve, with this being larger in large dogs compared to smaller dogs at the same dose in milligrams per kilogram. Our theory is that this is due to clearance, an established theory in allometric scaling, but we were also able to observe that dosing by milligrams per meter squared does not lead to an equivalent area under the curve between dogs of different sizes. One of our aims was to be able to recommend a formula for creating an equivalent dose in terms of area under the curve between dogs. Unfortunately, due to the uncertainty around our values in the nonlinear regression equation I showed you, this is not something that we were able to achieve. In terms of limitations, unfortunately, we were unable to recruit the number of dogs that we wanted, and this contributed to the degree of uncertainty in our results. We also had incomplete observations for several dogs who had increasing prednisolone concentrations past time points we would have normally expected. This also increased uncertainty in our area under the curve estimations and therefore our results. Given we could not perform an intravenous dosing phase, we also had to base our bioavailability assumptions on previous work and cannot be 100% certain that area under the curve is variable due to clearance alone. Finally, there is some potential that long storage times for some patient samples may have affected their prednisolone concentrations. The longest storage period for one particular sample was 15 months. We did aim to analyse samples every 6 months, as we knew prednisolone was stable for at least this long, but this was not possible in terms of delays in developing our methodology around the LCMS. So finally, my conclusions at the end of my master's research. So the Vet Compass study allowed us to describe how prednisolone is used in the Australian dog population, demonstrating that it is used most commonly as an anti-inflammatory and typically at an appropriate dose, although there was some infrequent use of inappropriately high doses. Clinicians do appear to factor weight in when dosing dogs and dose larger dogs less on a milligrams per kilogram basis. But we would recommend further research into clinician awareness of dosing guidelines for large dogs receiving high prednisolone doses for immune-mediated disease, as this presentation was relatively uncommon in our data. In terms of the pharmacokinetics study, we confirmed our hypothesis that body weight influences area under the curve, and we were able to describe this relationship, albeit with uncertainty. We had the unexpected finding of appreciating highly variable absorption times in our study population, but this information is still useful as it can inform future studies. We would recommend further research on a larger cohort of dogs with longer observations, which would allow a clearer or more accurate description of the relationship between body weight and area under the curve. And this may eventually allow for a calculation that clinicians could apply to provide an equivalent dose between different body size dogs. Such a study or future studies would also ideally relate area under the curve to a pharmacodynamic effect, as there is no available therapeutic drug monitoring for prednisolone in dogs. So here are my references, and I can come back to those if anyone wants to chat about them. And before I move on to questions, I have a lot of people to thank. So obviously Julian, Anke, and Natalie for being my committee. Mark Stevenson for statistics supervision and manuscript review. Andrew Woodward for supervising the pharmacokinetics project and helping me with the data analysis. He did all of that. That was amazing. Dr. Michael Leeming at Bio21 for helping me develop the methodology around the LCMS and calculating plasma prednisolone concentrations from that data. Babak, who some of you probably know, for helping with the LCMS as well and sourcing materials. Liz Tudor, who was my committee chair, and Ted, who was also originally one of my supervisors and on my committee. And finally, the American College of Veterinary Internal Medicine, who provided a grant for the population pharmacokinetics study. I hope I haven't forgotten anyone, but anyway, yes, thank you. And any questions?
Wonderful. Thank you so much, Bonnie. So yeah, and Bonnie has been very modest because, as you can all imagine, Bonnie has been also quite disrupted by COVID and, you know, not being able to go where she wanted to go, and also in terms of her supervision, that has been a little bit interrupted there. So if there are any questions, then please come forward. We also have the chat, and Aaron is kindly helping us to monitor that and keep an eye on it. But yeah, I open the floor for questions. Simon.
Hi, Bonnie.
Hi.
Yeah, that was a fantastic study, really interesting. I was just wondering, with prednisolone, some dogs may have been on prednisolone for a long, long period of time, whereas others, it would be a relatively short period of time. Presumably that data would have been captured in the Vet Compass data, but I'm just wondering whether really long-term treatment with prednisolone would have any effect on pharmacokinetics, you know, causing changes in hepatic enzymes and things like that. Whether you notice any of that with the Vet Compass data?
Yeah, so I guess with the Vet Compass data, we didn't actually look at how long the dogs had been on prednisolone for. I guess to sort of get an understanding of my the data that I was receiving, I would get a medical entry for an individual dog at a singular time point. I wasn't going back and reviewing their longer term medical history. And the notes often wouldn't necessarily allude to whether this was a repeat script or not, because of the time it would have taken to get that additional bit of data, and that we weren't necessarily relating it to our research questions in terms of how prednisolone was being prescribed. I don't actually have any information from Vet Compass in terms of how long each dog was on prednisolone for. In terms of the pharmacokinetic aspect, I guess we would typically expect prednisolone to be fairly rapidly cleared. We did take a baseline sample from every dog before we gave them their morning dose to understand if there was any residual prednisolone from the previous dose. In terms of how it would impact their, I guess, clearance or metabolism of prednisolone being on it for a long period of time, that's a great question. I actually don't know the answer to that. I haven't come across any studies that have necessarily evaluated that, but it's a good question. I'll see if there are any around that I might have missed. Because yeah, the dogs in that study had been, like the population pharmacokinetics study, some dogs had been on it for a long period of time, others a short period of time.
Yeah, it's maybe something that could be built into a future study. Yeah. Thanks.
Bonnie, fantastic presentation. Thank you. Just a question which I've just posted actually in the chat room as well. And apologies if I missed this because I was teaching and missed the start of your presentation. But how specific is the assay for prednisolone? And is there any possibility that endogenous release of cortisol could have interfered with your measurements, for example, in the dogs that appeared to have the delayed absorption? Were they just more stressed?
Yes. So I guess in the dog that had super delayed absorption, like that dog was literally charting at like zero, like shouldn't say charting, that dog literally had zero detectable prednisolone until time point 6. But if I understand your question, I guess, could their peak have been contributed to by cortisol? My understanding of the methodology is it's very specific. In terms of factoring in, like, I'm going to explain this really poorly now, even though it's been gone through with me a number of times, but I guess the, intrinsic properties of any steroid, the way LCMS works, I guess, is that there is energy applied and it's broken into fragments, and the fragments kind of give each individual molecule kind of a unique signature that allows it to be picked out from other steroids or any other molecule in the background with relative precision. So my understanding is the methodology is that cortisol shouldn't have interfered with prednisolone concentrations.
Thanks, Bonnie. Thank you.
Okay, are there any further questions?
I haven't actually looked.
Hello, everyone. Bonnie.
Yeah.
With the dosing in your vet companies, how much do you think of that change for body weight is accounted by tablet size, given that sort of 20 milligram tablets is probably about as large as you usually stock?
Yeah, so that's a good question. I guess, prednisolone tablets come in 1s, 5s, and 20s. There is also a prednisolone liquid if people wanted to be more sensitive in terms of their dosing, but that was actually, I don't have that data right in front of me, but that was actually very rarely prescribed in the Vet Compass data set. We're very aware that that definitely could place, a restriction on a clinician and being able to give 2 milligrams per kilogram or 1 milligram per kilogram exactly. And I guess that was part of the reason why we sort of created that intermediate dose category from 1 to 1.5 milligrams per kilogram per day, and didn't want to necessarily make an assumption about what effect the clinician was aiming for in terms of, because our primary interest was differentiating dogs that were meant to get an inflammatory dose or an anti-inflammatory dose from dogs that were meant to be getting an immunosuppressive dose. But you're completely right. Tablet sizing does create a limitation, and kind of can only be dosed sort of to the nearest 5 milligrams based on the tablets that are available on the market.
All right. Do we have any further questions for Bonnie?
None that I can see there. As usual, if anyone has any questions, please get in touch with me and I'll put you in touch with Bonnie, but I think you have her email address. And yes. I'm sure she'd be happy to discuss things further. Any final questions from the group? Any final comments, Bonnie? Congratulations on your presentation. There's a number of people who are adding their congratulations, and yes, you have soldiered through the pandemic and done an astounding job. So congratulations, virtual round of applause. Thank you to Anke for joining us as the host. Thank you for presenting, Bonnie, and we might finish up there.
Thanks everyone for coming.
Thanks so much. Take care, everyone.
Terrific.